with the Immune Deficiency Foundation, one of the members of the American Plasma Users Coalition, better known as A+. And on behalf of A+, I'm very pleased to be able to produce the third webinar in this webinar series dealing with implementation of the Affordable Care Act. A+ consists of patient organizations whose patients use and need plasma products, such as patients with primary immunodeficiency diseases, Guillain-Barré syndrome, chronic inflammatory demyelinating polyneuropathy, alpha-1 antitrypsin, and idiopathic thrombocytopenic purpura. All of us have joined together to produce these webinars. There's a few housekeeping items before we begin. Tonight's webinar is scheduled for 90 minutes, which will include approximately 30 minutes of question and answer at the end. This program is being recorded. Therefore, the organizer will be muting all participant lines during the presentation. Instructions on how to unmute your line for the Q&A session will be provided at the end, and the control panel on your screen can be minimized by clicking on the orange arrow to the left of the panel. Each A+ organization will be provided a downloadable media file of the webinar in its entirety, including the written material sent earlier to you to post on the respective websites of each of the participating organizations. As Michelle indicated a few minutes ago, and for those who are new, is that hopefully you have received information today by email with certain materials that will be referenced tonight. If any of you did not get that or did not receive it, we will make sure that you will receive it, unfortunately, after this webinar. But all those materials will be on people's websites when we get that to them. Don't worry if you don't fully understand everything in this webinar. You know, hopefully we'll be able to fill in some blanks, and hopefully you will have a better understanding of the topic of Affordable Care Act. You will receive an evaluation survey of the webinar, and it really is very, very important that we have your feedback, and we urge you to please take the few minutes to fill out the survey form. I want to say thanks to Michelle Rice and Marla Feinstein of National Hemophilia Foundation, Jim Romano of Patient Services Incorporated, and Marlene Urban of Alpha One, and of course our presenter JoAnn Volk of the Health Policy Institute at Georgetown University. With that, I'll turn things over to Michelle to acknowledge our sponsors and describe the goals of the webinar series. Michelle?
Great, thank you. I am actually JoAnn. Can you go ahead and click over to the next slide, please? Okay, I have it. Forget it. Okay, our webinar producers for tonight, as Larry just mentioned, Georgetown University Health Policy Institute, JoAnn Volk, who has been the speaker for the last couple of webinars and also has produced the documents that we've provided to you as handouts for the webinar, and has been an excellent resource for those of us on the A+ Coalition. And as Larry mentioned earlier, here are all of the members of the American Plasma Users Coalition. Our program sponsors for this webinar series, our lead sponsors are CSL Behring and Pfizer, with supporting sponsors Credo, Baxter, Bayer Healthcare, Biogenetic, Grifols, and Novo Nordisk. Without their help, we would not be able to produce these webinars and have them available for your review later on our websites. I'm going to turn this over to JoAnn for her to explain the goals and objectives of the webinar.
The objectives of the series, and this is the third, as Larry said, in our series of webinars, is to help advocates in the states understand how the Affordable Care Act will affect your care. and to understand what it means for healthcare specifically in your state, because as we've talked about before, much of the Affordable Care Act relies on states to implement the key provisions and gives them pretty broad flexibility to do so. So we hope to arm advocates with the tools you need to make sure that the implementation in your state meets the needs of patients and responds to the concerns that you raise. All right, for this particular webinar, we're going to focus on the essential health benefits and network adequacy provisions. Both are pieces of the Affordable Care Act that, when taken together, will really mean whether or not patients can access the care that they need, not just which services are covered, but whether or not the providers are there to make the services available. We'll be updating you on the EHB selection process because we sort of have passed a milestone here on, after September 30th. The essential health benefits, to remind folks, and we've talked about this before, are the minimum set of services that all insurers must cover in plans they sell to individuals and small employers. So this is not a requirement that's limited to the exchanges. It will apply to all individual and small business policies sold in the state. Network adequacy, on the other hand, as we're going to talk about it tonight, are standards that apply specifically to the insurers that want to offer coverage in an exchange. There are a number of different criteria that insurers have to meet, and this is one of them, to be a qualified health plan in the exchange. But together, these two things, as I said, will affect what care is covered and how easily it can be obtained, that is a provider in network and taking new patients. So where are we now with the essential health benefits? As I said, we had a September 30th deadline that the Department of Health and Human Services, HHS, put out there for states. All we had to date was guidance from HHS on how they are proposing that states select an essential health benefits. And this was delegated to each state to determine what their EHB would be from a number of different plan options that currently exist in their market, small business plans, state employee plan, and so forth. And they were supposed to have chosen by September 30th, according to that bulletin that was released in December of last year. According to our research, about 22 states met this deadline, and there were a few more that were in the final stages of making a selection. And most states ended up choosing a plan in their small group market to comply with the essential health benefits. There were just a handful of states, I think 3, that chose their state employee plan, and one state whose plan they chose is both the largest HMO and the largest small group plan. And we can get into more of that in questions if folks would like to. But the bulletin also said that states that don't select their essential health benefits will get a default plan, which HHS said would be the largest plan in the small group market. But we do not expect to see the rule from HHS, the actual formal rule, because all we have is suggestion from HHS how states might do it, but not formal rulemaking until after the election. And I'll just point out here that one of the things we've heard is that HHS will actually release 2 different rules. One is the actual rule for how states should choose their EHB. You might note after the fact, after about half the states have done that, and that's the proposed rule that they'll take comments on and everything else and put this in a formal process. The second would be a release that actually says that the Secretary will adopt the recommendations from states where she has them. So for those 22 states that have already submitted something, the second publication from HHS would say, and in these states, this is what it would be. They actually do expect that somewhere between that first rule that becomes the official rule for how states should go about this and the second rule that publishes what states select, but there might be a handful of states that would still then submit a selection. You might have heard in some of the press coverage that some states are saying we can't possibly make a selection until we have the actual formal official rule from HHS. So once they have that, there might be some states that would quickly opt to make a selection. So that number of 22 might grow by a handful. So there are a few steps. After a state actually chooses the plan, there is work still to be done. And that is that they may need to supplement the plan to meet all 10 buckets. You may recall from our earlier work that there are 10 buckets outlined in the Affordable Care Act that must be included in the essential health benefits. The plan that the state chooses may not automatically cover all 10 buckets, and so the state would have to supplement. The guidance says that outlines up an approach that states may take to do that, and that is to basically look at some of the other benchmark options and see if, for example, they cover pediatric, oral, or vision, and borrow from that plan to make their EHB selection whole. As an example of what a state has done, California, which has adopted legislation selecting a plan for their EHB, decided to fill the bucket of pediatric vision care by borrowing from the Federal Employees Health Benefit Plan, which is a relatively generous plan, and to meet the pediatric oral care bucket by borrowing from the state's CHIP program, the program that's for children. And states could also then enact additional consumer protections on top of actually identifying how those buckets are filled. An example of this is California, again, put in their legislation that insurers cannot make substitutions within the 10 categories or across the 10 categories. So they've limited the insurer flexibility to move things around and say they're still meeting the state's requirement for essential health benefits. There is still work beyond filling in the gaps, and that is operationalizing the application of the standard to new plans. So insurers will have a set of products or plans that they already sell out there in the market. They may have to modify them to meet this new standard and match up with whatever the state chose. So that may require just small tweaks to the products that they already sell, or it may require wholesale changes. But the question is, how will the state or, frankly, consumers know how well insurers are meeting the standard? Is there going to be any oversight, or will insurers get to just check the box and say, yep, the stuff we're selling now to individuals and small businesses meets this requirement? And this is important because, remember, one of the main goals of the essential health benefits is to give, well, I should say two of the main goals is to give consumers some certainty of the benefits they're going to get and to have some basis of comparing plans. But if we don't have a real way to understand whether or not insurers are meeting the requirement, both of those goals are undermined, and consumers can't be sure that they're comparing apples to apples when they're shopping for plans. And then we'll talk more about another key step here, which is monitoring for access problems. So once the benchmark has been selected, what does it actually look like in use for real patients out there, especially ones who have chronic, serious, or rare conditions that will really test the limits of the essential health benefits. We know that there may be gaps in coverage. We know absolutely that plans are allowed to carry or include non-dollar limits like treatment visits. That's still allowed in essential health benefits. So monitoring that will be a key part of the work to come on essential health benefits. So I do want to just be clear, though, because I know this has come up before. I wanted to just spend some time being candid about the limits of the essential health benefit. It will create a new standard that will improve coverage for many by setting this floor, but there are still some shortcomings in the way that the law was written and the way this will be applied. The law says that the law does not address the Secretary defining medical necessity across all plans, and that's going to be a key part of whether or not consumers can access services. The rule and the law has been clear that plans can continue to do utilization review and that they can impose non-dollar limits, as we just talked about. Both of these can pretty seriously limit access to care. And we still don't know if HHS is going to deal with the insurer flexibility to do substitutions. They noted in the bulletin we saw more than a year ago, or I mean a little less than a year ago, December last year, that they propose that insurers may be able to do the substitutions I talked about, whether within the category or across categories. California now is the first state that we know of that's actually prohibited that, so we have a little bit of a test case coming up. Is HHS going to allow states to consider the federal rule the floor and enact more consumer protective restrictions for their residents, or did California go beyond where HHS will allow them to go? So there are, now that I've told you about the shortcomings, there are official opportunities to improve the essential health benefits. For one, the bulletin said that this is a state-based approach that HHS intends to be in effect for the years 2014 and 2015. Beginning in 2016, they said that they will be reviewing this approach for future years, whether or not to continue it, and specifically how they deal with state mandates. The law requires the Secretary to periodically review and report to Congress on a number of different pieces of how the essential health benefits is being applied. And they ask specifically for whether or not problems come up with patients accessing needed services and care, and suggests that when the Secretary identifies gaps such as those, she must suggest a way to fill in those gaps in her report to Congress. So there's an official opening here to demonstrate where there are shortcomings and to propose solutions. I think that though this was originally delegated to the Secretary, I think with the delegation to the states that choose the EHB, there is a role for states to play in monitoring gaps and identifying those for the Secretary, and for patients to help identify those with their real world experience with this. Okay, next slide. Moving now to network adequacy. This really is a companion to the essential health benefits because it will ensure that patients can obtain the services outlined in that package in a timely way. So in some respects, having the paper that says that the services are covered is meaningless if they're not the providers there to make the services available, that they're taking new patients, that you can see them in a timely way, that the specialists are in network that you need. This particular requirement, as I said, applies specifically to exchange plans, unlike the essential health benefits that we were just talking about. It is part of the plan certification process for plans to be to participate in the exchange, offer coverage there, and receive federal subsidies. It falls under a category of functions known as plan management, and we'll come back to that term later. Advocates will need to look at how the standard is set and how it is enforced. This is really a two-pronged action for advocates. Next slide. This is in this screen what the rule actually says about network adequacy. It is this simple definition. A network that is sufficient in numbers and types of providers, including providers that specialize in mental health and substance abuse services, to assure that all services will be accessible without unreasonable delay. And then in addition, it must include essential community providers that serve predominantly low-income and medically underserved individuals, with a specific reference to 340B providers. And again, this is taken from the final rule on exchanges. Okay, the next slide. And the thing to note about the way HHS has defined it is the protection is pretty broad and general. By comparison, some states have in their state network adequacy standards for HMOs or in their contracts with Medicaid managed care plans much more specific and detailed protections, like a provider in an urban area can be no more than 30 miles or 30 minutes, or I'm sorry, primary care is no more than 30 miles or 30 minutes, specialist 60 miles or 60 minutes, wait times of no more than 2 weeks for an appointment for non-urgent care, and so forth. None of that is in the rule that I just read to you from HHS on exchange plans. HHS said in putting forth this rule that it will help level the plan to ensure that all services will be accessible, but it doesn't specifically address what this means for specialists. And then the essential community providers, there is a question of how 340B providers get defined, and I understand this is still pending at HHS. Is it merely those that are eligible to participate in the program or are actually participating? And there is a difference among those providers. So on the point of setting the standard, I said that there would be a setting the standard and enforcing it. Just by way of background, 20 states currently have some rules for their commercial plans that they apply to plans operating in their states. Of those 20, 7 have specifically adopted what's known as the NAIC model law. That's the National Association of Insurance Commissioners, which regularly puts out model laws for state insurance commissioners to get adopted in their states. There is one on network adequacy for managed care plans. 7 states adopted that, 13 more adopted some version of that, and that's what exists currently. But again, that's for managed care plans, so there's a bit of a disconnect between the rules that exist in some states and the rules and the types of plans you'll have in an exchange. Not all the plans in the exchange are going to be managed care plans. And in fact, the market has changed pretty dramatically from the time that this NAIC model law was adopted in the 90s. We've had a decrease, a drop in the number of HMOs, which are the very closed network plans where you have to go to an in-network provider. That's where the care can be obtained, to a world now where we have more PPOs, preferred provider organizations, where there is still a network, but enrollees have the option to go out of network, although it may cost them more in terms of their co-pays. So it's a different world we live in now, and so the model bill for managed care plans may not work well in that regard, but it also doesn't address two ACA requirements that apply to QHPs. One is that the networks must include mental health and substance abuse providers, and the second is that it must include essential community providers. Neither of those are explicitly addressed in the state rules in existence now. Next slide. So states that have the rules will have to decide if they apply the current rules to the QHPs with some tweaks. Do they want to do a broad protection like the HHS final rule says to ensure access without unreasonable delay, or do they want to get more specific and detailed in the criteria such as miles and minutes to appointments or providers? But in all cases, they want to be sure that they have a level playing field with the plans operating outside the exchange, again, for this reason I talked about earlier, known as adverse selection, that the plans that seem better suited to sick patients will be the ones that where the costs go up as more and more sick enrollees go to those plans. And the plans with tighter networks, for example, might attract a healthier population. So one option is, of course, you could either apply the rules from the outside market into the exchange plans with those tweaks for the social community providers and substance abuse and mental health providers that we talked about, or you could do it for the QHPs inside the exchange and extend it out to the plans operating outside the exchange, so there really is a level playing field from that direction, from inside the exchange out. And there may be plans, rules now that do incorporate mental health, since under the mental health parity law, many plans do already offer those benefits, so that may not be as big a mismatch as it may seem. Next slide. The other key piece of this, beyond just setting the standard and putting it out there, is actually enforcing it. So states can do a review before certifying plans, and many use a software that allows them to do that, to just sort of check and make sure that a plan, they line up with the providers with potential enrollees and can sort out whether or not it's an adequate network. That's not a particularly difficult process, but monitoring the plans once they are operating is a bigger deal. So many states right now, for their commercial plans outside an exchange, respond to complaints from patients. Either one-on-one they respond to them, or certainly where they see a pattern of abuse, they may step in and do a bigger, what they call market conduct exam, where they really go in and sort of audit the plan on a number of different factors. And then they can also respond to reports from providers that we heard from some insurance commissioners when we were doing a paper on this topic, that they often will hear from providers that they're losing a contract with a plan, and that's another key source of getting information about changes in the network. But advocates can also push for states to require reports from the plans on requests for out-of-network care to sort of start capturing how many people are looking for care that cannot be obtained with an in-network provider. Next. All right, but let's just assume that the network is not sufficient for all patients at all times. It is worth the effort to put in place some consumer protections. And actually the NAIC issued a white paper, which is sort of a way to update their model law to say, let's look at the model law we have now and what states will need to do under the Affordable Care Act and qualified health plans operating in the exchange. And they do note that there are a number of areas where states can enact consumer protections for those consumers that cannot get care in network. One is to say that patients should have no greater cost sharing for care that can only be obtained out of network, as one measure that the network is not adequate for that particular patient. Another is to have some protections for changes in provider network in the middle of treatment. So if the provider you're getting a treatment from, ongoing treatments from, is suddenly somehow designated, they lose a contract, and the provider that at one point was in network is now out of network, and your cost should go up. There could be a cap on, or either a transition period or a cap on no greater cost sharing. It's not the patient's fault that the provider they've been working with is now in a different category. and so they have to choose between either switching providers or paying a lot more money out of pocket. You can enact some protections against that. The rules for networks should consider a team approach to treatment and care. So, for example, if you're in a hospital that's in-network for surgery, the radiologist, the anesthesiologist should all be considered in-network. And to take into consideration referral patterns that doctors may use, particular specialty docs or hospitals. And finally, to have some protections against balance billing. Balance billing is, for those that don't know, is when a patient receives care out of network and the out-of-network provider gets reimbursement from the plan. Balance billing is when the provider comes back to the patient and asks for the difference between what they normally charge and what the plan reimbursed for. And for some treatments and some providers, that can be tens of thousands of dollars. Some states have enacted protection against that to limit the ability of providers to do balance billing. So where exactly can you go if you wanted to engage and play a role in your state's decisions to decide how to implement these two provisions? We've talked a lot about the essential health benefits, and much of that work is already done, as we've talked about, but there is more to be done after identifying the benchmark. So you can ask your Department of Insurance that would have to issue rules, the governor who may have been involved in the selection, or the legislature who can enact additional protections. How are they supplementing the plan to meet the 10 categories? Are they going to generous coverage to fill in things like habilitative services or children's oral and dental and vision? Are they considering additional protections, as California did, limiting insurer flexibility? How are regulators going to ensure that the plans are actually meeting the requirements? And how will regulators and legislators monitor the plans to know if the services are adequate? So looking at where some of the decisions actually get made for network adequacy, this is a function that falls under plan management, as I said. In a state that's going to pursue a state-based exchange, and there are about 16 of those now, this is something that the state will be doing as they set the criteria for the qualified health plans in their exchange. It is also possible that a state that is not able to do their own exchange but doesn't want to just turn it over to the feds and instead wants to do a partnership exchange, which is an exchange that they run in conjunction with the feds, where the state does some functions and the feds do others. If the state elects to do the plan management functions, they can retain these decisions, and you still have a pathway to have a voice in how those get defined. If the state does not do an exchange, either in partnership with the feds or a state-based exchange on their own, and it is a federally facilitated exchange, it's going to be a lot harder to try to have your voice heard for how those rules are set. For one thing, HHS cannot possibly enact any rules that would affect the plans operating outside the exchange. Their room for making decisions is just within the exchange. So you automatically have an opportunity for adverse selection and a difference in the rules that apply inside and outside. If you're wondering which state you live in, and if you're going to have a state-based exchange or a partnership exchange or a federally facilitated exchange, states have to notify HHS by November 16th by submitting something called a blueprint, where they say how they're going to officially declare which exchange they're going to operate and how they're going to do it. And HHS has told states that even if they think they're going to get to a state-based exchange, they should sort of assume a plan B of what they would do if they couldn't do that and had to operate a partnership exchange to consider how they would do that. So I guess the takeaway on this particular slide is if you want to have a role in the decisions, you're much likely to be able to have that role if it's a state-based exchange or a partnership exchange where the state is doing these plan management functions. If it's entirely turned over to the feds, for example, in places like Louisiana, Alaska, South Carolina, Texas, and Wisconsin, where we expect a federal exchange, it's going to be a lot harder for advocates to have a say. So if your state is doing a state-based exchange or plan management in the partnership, these are some of the questions that are worth asking. To establish clear authority, is it the Department of Insurance or the exchange who will be enforcing and monitoring these rules? States have to clearly delineate who's in charge. The exchange can just accept the Department of Insurance's review of networks and say that if it flies the DOI, it's good enough for us. But if the standard is different, the exchange is going to have to do their own review. They can build on the Department of Insurance's review and apply their own criteria. If monitoring relies on the existing Department of Insurance process that includes the patient and provider reports, it's worth asking how complaints are resolved and at what point does the department step in and do a broader review instead of considering them case-by-case complaints and really dig in to see if the network is overall inadequate to meet the needs of enrollees. And finally, will the exchange require reports from plans on patient requests for out-of-network care? This is a protection we talked about earlier that advocates can push their states to include in their enforcement approach. So to wrap up this part of our webinar, the network adequacy standard and the essential health benefits will need to be defined soon. There is not a clear drop-dead date in HHS's view yet, but at some point it's a sort of fish or cut bait for the health plans. They need to know the rules that they're operating under, and they need to start retooling their products and getting them out there. Remember that the open enrollment for the exchange number 1, we're less than a year away from the first person being able to enroll in a plan. Coverage doesn't begin until January of 2014, but you can start to, the exchange basically needs to be able to allow people to consider their plan options on October 1 of next year. So somewhere between now and October 1 of next year, the insurance companies are going to have to know the rules that they're working with to put the products out there and get them approved. And we don't know what that date is, but it's not too far in the future. But both can be revised if advocates can demonstrate where they fall short for patients. The essential health benefits comes with an official opportunity, as I said, in the law for the Secretary of HHS to report to Congress where there are gaps in how they should be addressed. And states and advocates can play a role in documenting where the essential health benefits fall short. And the network adequacy may require a push to modify or make stronger in the future. There's not an official opportunity to weigh in, but certainly if plans are not providing services in a timely way, advocates can push for states to either revisit the standard itself or beef up enforcement. And just one final point on the network adequacy. This is really a place where plans may put a lot of effort to differentiate themselves from other plans in the exchange. It's one way to offer a lower cost plan is to have a tighter network. And it's also another way to gain market share if they can say that they're the only plan that has the premier hospital in the area or something like that. So this could really be an area where you see a lot of plan focus on how they define their networks and a point of competition between plans. So it's going to be a fluid area worth watching and absolutely means whether or not you as a patient get the care you need. So we'll take questions, but I also wanted to point out just a few words on the materials that Michelle said came your way tonight. One is a template for, and it is just a template for a letter that you can send to a member of your legislature or your commissioner of insurance or whoever is either in the driver's seat and or an advocate and friend for your community to ask for a meeting to open to discuss these issues, essential health benefits and network adequacy. It's just a letter that asks for a meeting and puts the issue on their before them. And then we've also included talking points that when you get that meeting, how you can raise the issue of essential health benefits and network adequacy. You'll notice that a lot of the points are similar to the ones we reviewed with the webinar tonight, but there's also background information there for you to talk about how the rule defines these things. And then finally, way that it doesn't for other patients. So do you want to open it up for questions either?
Sure. I do want to ask, I did get one question or actually a request for clarification, and this is probably more specific to the people in the hemophilia community, but when we talked about 340B providers being considered essential community providers under the ACA, and plans being required to contract with essential community providers. Just can you clarify, I guess, for the group what exactly that means? I think, does that mean they're going to contract with them for all services? Does it mean they have to? Does it mean?
Well, we don't know this yet. This is one of the questions that hopefully will be addressed in the rule. And all we have is what the rule says. But, there is a difference between those that are eligible to participate in the program and those that actually are, and for which services, as we said. So this is something that hopefully the rule will address.
One of the things in conversations that I've had with CSIO is that what I've heard is that they are not requiring, and this was in the regulation, they're not requiring plans to contract with essential community providers for all of the services they offer. They're encouraging them to, but they're not requiring them to. And I think that the states have the ability to make a decision to require that if they so wanted, correct?
Yeah, because it leaves broad flexibility to the states. Okay. And they specifically note that in the the final health insurance exchange rule, that they chose, while some people asked for the rule to be more prescriptive and detailed, but they opted for giving states flexibility to do with it as they saw fit. So one could argue that that's an appropriate way for states to exercise that flexibility.
Okay. And just to remind everyone, the easiest way for me to know if you have a question and I can unmute your mic is you'll see where you can raise your hand on your on the control panel, and if you do that, I will unmute your phone and announce who has the next question. Anybody? Ray. Ray, I see that you have a...
Yeah, can you hear me?
Yes.
Okay. What I wanted to know is, I heard about enrollamerica.org. Will that be a helpful tool? Did you guys hear
about that? Is that a helpful tool? Is that repeat your question?
Enrollamerica.org.
Mm-hmm.
I was on a webinar the other night. Apparently, they are going to have, it's going to be an assistance website to get enrolled onto the exchanges. Have you guys checked into that site at all?
My understanding of Enroll America is to share with advocates and states which is supposed to be have a similar function as the navigators, but a little bit different. But the point is that Enroll America, I understand, is going to be a way to sort of put out best practices for enrollment, but to not actually be a place for people to sign up. Does that make sense? I mean, there's been a lot of lessons learned from Medicaid and CHIP about how to enroll people, and I think they're going to be sharing some of those ideas, but not to actually enroll people.
Okay, Ray, does that answer your question, or did you have another? Okay, Ray, does that answer your question, or did you have another?
No, that's exactly what I was looking for, because that's what I heard.
Okay.
About the assisters and the navigators.
Okay, let's see. We'll go to our next question. Is Glenn Moniz?
Hello, can you hear me?
Yes.
Okay, great. This is kind of a terminology question. It seems like EHB, or essential health benefits, and benchmark plans have become kind of interchangeable expressions. Is that kind of how it is now? Because I know one time we were talking about EHB more as what was included in the federal law, and then the benchmark plans it would boil down to. but it sounds like we're kind of interchanging them, and maybe rightly so. And I just, since we're going to be communicating with constituents and media and whatnot, want to make sure that we're kind of using correct terminology. So am I getting that right?
Yes, you're right. I was basically moving them in and out equally, but I think for your purposes, for communicating with legislative or Department of Insurance or the Governor's Office, the best term to use is essential health benefits. I think the benchmark piece of it comes in because states had, 10 benchmark plan options to choose from, and then that's how it sort of got picked up, that the EHB benchmark. But I would refer to just essential health benefits to be clear that you're talking about the requirement itself. I guess I'm going to chime in here. I realize I don't want to undersell the opportunity here or the role for advocates with the network adequacy and essential health benefits. I think that with everything that states have to do to get these exchanges up and running, and it's not just the exchanges, and there's going to be a bunch of other insurance reforms that take effect in 2014, limits on how much insurers can charge and no pre-existing condition exclusions and a lot of good things that all warrant attention. But I think once they've developed some rules, like they've selected their essential health benefits or they've set the network adequacy rules, it's easy for the state, in the mix of everything else they have to do, to sort of say, okay, we've checked that box. What do we need to do now? Sort of drinking from the fire hose situation. And I think advocates have a very important role to play in just sort of, frankly, needling states to say, yeah, now you have to pay attention to how this actually works out there in the real world, and to help document that. And whether it's regularly certain providers are not in network across plans, or within a certain plan there's regularly problems that the department should pay attention to and go in with that broader audit that I talked about is an option for them now. If the essential health benefits is regularly not meeting patients' needs because of, you'll see the talking points get into things like utilization review, or if there's fail first policies for the prescription drug formulary, or other tools, frankly, that insurers use all the time to set up some barriers to patients, expensive patients, getting access to expensive treatments and services. So it's a really important piece that can quickly get overlooked, but it's where the rubber hits the road, really. And it's not easy work to keep track of all this, and it's probably not going to be a welcome pitch to the insurance departments that they have to monitor this stuff more closely, or the exchange in the case of the QHPs, but it's essential work.
JoAnn?
Yes.
This is Larry, and I just want to follow up with that. I think it's if nothing else, it's probably a great idea of just going to whoever's the decision makers in your particular state and demanding that whatever they put together, that they have a place where there is accountability for what is being taken place, that there is going to be review, oversight, and who's going to be responsible for that oversight, who's going to be responsible for handling complaints and having the power to do something about it. I mean, if nothing else, that is one message that you can take to your local state to make sure that you have consumer protections in there to make sure that somebody is held accountable for what happens in the actual insurance marketplace.
Okay, I have another question from Jose that says, why would plans outside an exchange that exceed the adequacy standards be discouraged?
Well, the problem arises that this adverse selection that I was talking about is a wonky insurance term, but basically, if the rules that apply to the plans inside the exchange are different from the rules that apply outside, then you have a situation where sick patients go to some plans and healthy patients go to the others. So in this example, if the networks outside the exchange are really tight networks that are very limited with access to specialists or HTCs or whatever it might be, and the only place you can really go if you're a person with hemophilia or with cancer, stage 4, some complex condition that you have a specific hospital or provider that you need to get to, if only those providers are available in the exchange, that's where the sick and costly patients are going to go. And there are some protections in the Affordable Care Act to protect against that situation, and I don't want to get into that completely technical discussion. But frankly, it's not entirely clear that they're going to work as well as they should to protect against that situation where plans benefit by cherry picking, trying to turn away the sick patients with all kinds of barriers and enroll only the healthiest. And it's that unlevel playing field where there's different rules inside and outside that sets up that situation. Does that help explain that?
Okay. We have another question from Bob Robinson.
Hi, this is Bob Robinson from the Bleeding Disorders Alliance, Illinois. One of the things we're having luck with right now is that as the private insurers are looking at the EHB and trying to figure out what they're going to try to do to match the plan that's being recommended in Illinois, they're very, very interested in our chronic condition, and especially comprehensive care. So it's opened up a communication source with us to really kind of educate them and talk about what it means to us. So, you know, yes, we know that this is, you know, they're trying to do this for a profit. They're going to be looking at it, you know, to figure out probably minimally what they have to do to stay in this competitive exchange. But I just want to encourage as advocates that don't block that door, that those, you know, there is opportunity and to build relationships and to try to get them to understand. And thus far, it's been nothing but positive for us in all of those situations. Now, we have yet to see what the actual plans are going to come down to, but we've kind of opened up, and we think we've improved care through these early stages right now because these companies have started calling us more to talk about coverage for patients that are currently, you know, under their plans, and making sure they're delivering what we've now shown them to be kind of the best standard of care for hemophilia patients. So,
and not to put you on the spot, how did that come about? Was that just something that you were knocking on your door? How did that?
Well, it's been, we've had a long-term advocate. What we have as opportunities right now, you know, don't forget those private insurers. So they're going to be making important decisions about our care, and we're really the best people to tell them, you know, to at least try to build a partnership with them, to educate them what we need the most and how to do it the best, and then, you know, then fight it out when they don't follow our guidance. But if you build the relationship right, you should be able to reach some kind of compromise that is at least better than not being at the table at all.
Mm-hmm.
And they are hungry. They're hungry to know, because they want to spend their dollars. You know, they want to make the most profit they can, and they want to provide, we have the sense that they want to provide the best care they can with the most profit, which sound like they're opposing forces. But
well, no, I mean, this is one of the goals of the exchange, is that when consumers can do apples to apples comparisons of some of these differences in, you know, consumer assistance and or customer assistance and quality, these are the factors that plans may compete on. Once some of these other things are made, you know, equal, like the benefits.
And there's where we're trying to get those standards put in place that, you know, no matter what your, you know, no matter what your plan is that you're guaranteed that one visit a year with a you know, comprehensive care facility. So for hemophilia. So.
Okay, well, we've got several other hands here, so let me move on to, let me see, Joy. Joy Millie? Joy, did you have a question? Okay. Let's move on. That one is, we'll come back.
Unmuted.
Ray.
Yeah, my question was real simple. I mean, how does Medicare and Medicaid fit into this?
How do they fit in? Completely different. Well, yeah. The central health benefits, it's going to apply to the Medicaid. Sorry for the feedback. The Medicaid expansion population. That there's some portion of that Medicaid world that's going to have to also meet the essential health benefits standard. But the network adequacy standards that we were talking about apply to the private plans and not Medicaid. And then Medicare is a whole different ball of wax for the 65 and older population, or those who qualify for other reasons. But you know, I think I said early on in the presentation, a lot of states either have, 20 states have some standards for their private plans for the network adequacy. Many states, as they move to managed care for Medicaid, have contracts that are much more specific requirements for adequate networks. And that's where you see the detail of the time and distance to primary care providers and specialty providers and appointment wait times and so forth. Very detailed criteria to meet. So it might be possible that some states would look to those requirements and just apply those to the commercial plans. But at this point, there's no official link between the requirements for Medicaid and those for the network requirements for the exchange plans.
Does that answer your question, Ray?
Unmuted.
Does that answer your question, Ray?
Yeah, pretty much. That's what I thought.
Okay. Okay. How about Glenn? Do you have another question? Glenn Moniz?
Hi, sorry, no, I just forgot to take my hand down.
Okay, how about Janice? Janice, did you have a question? It's hard to remember to take your hands down. Trying to see if anyone else had any questions. Joanna, did you have a question, or was yours answered?
Mine was answered.
Okay.
Thank
Does anyone else have any additional questions or comments or concerns? We will have these, we will have the presentation up on the website. We will have up the various handouts. And JoAnn, I know you talked about the template, but did you talk, did you address kind of what the purpose was behind the media sound bites and?
Yeah, I'm not sure. You know, this may have more limited use right now because states are wrapping up some of their essential health benefits choices, but to the extent that there is still some public forum for that in different states, this is just, as I said, a way to get the media to understand in, you know, the 2 minutes you may have or less that essential health benefits means something very different for patients that have rare and chronic diseases. And that's where this stuff gets defined. And if it works for those patients, then it's legitimately a good essential health benefits package. But it might be worth just reminding folks, for those that don't have it in front of them, the talking points that we have put together for that meeting that you're going to get with the template you use with your policymakers goes into a lot of the questions that you would ask, where Larry and I went heavy on sort of, you know,
Okay, any other questions? Just trying to see if I missed anyone. If you think of a question after, you know, the program is over and you want to call and, you know, or email and ask a question. I see Linda Ross, do you have a question or was your question answered? Oh, may have been answered. Okay, well then I want to thank you on behalf of the on behalf of the A+ Coalition for attending tonight. We will plan on having a 4th webinar, possibly late November, early December, so that we can talk about kind of what happens after the election. So please fill out, you will be receiving a survey after this is over. Please fill it out, provide us some feedback and some comments. If there's a particular topic that you want to make sure that we're addressing, that we're not addressing, please feel free to let us know that as well. And we appreciate you taking the time out of your evening to join us tonight. So thank you very much, and thank you, JoAnn.
Thanks. Good night, all.
Good night.